Good morning. I'd like to welcome everyone here, as well as on the internet and our YouTube channel to DeBakey Grand Rounds this morning. My name is Marvin Atkins. I'm one of the cardiac and vascular surgeons here at Houston Methodist. I have a couple housekeeping items before we introduce the speaker. So for those that are in the audience, please use the microphones to ask questions. We are broadcasting live to our worldwide audience via Vimeo and YouTube. The recording will be available to view within a few hours after we get finished and should be on our DeBakey YouTube channel. So obviously, please like, comment, subscribe, and share to our YouTube channel. And for our viewers on the internet, if you'd like to submit a question, please text the word DeBakey, D-E-B-A-K-E-Y, to 37607, and we try and get to your questions, please. We have some upcoming training activities here in the DeBakey Center. Cardiology for the non-cardiologists is on May 17th. Pre-intern training for vascular residents on June 16th. And we have the CV Fellows Boot Camp starting on August 8th. So today it's my esteemed pleasure and honor to introduce our Grand Round speaker. Dr. Bo Yang, MD, PhD, is the Frankel Research Professor of Aortic Surgery at the University of Michigan. He's an expert in the management of Marfan syndrome, Loeys-Dietz, connective tissue disorders, and all aortic pathologies. He has a basic science lab, which has been NIH funded, focusing on aortic disease. And most recently, one of his big interests has been in the hemodynamics of aortic root enlargement, to the fact that he was able to develop a specific procedure that now is taught for the last 3 years at the Society of Thoracic Surgeons annual meeting. And so we've been honored to have Dr. Yang spend last night with us at dinner, tell us about the aortic program at Michigan, and he's going to tell us a lot more today about the Y or Yang annuloplasty technique and its benefits and how it should be the way that we treat patients that have small annuli and aortic stenosis. Oh, Yang, please.
Thanks, Marvin, and thank you, Mike and Marvin, everybody here for inviting me to give the Grand Round. It's an honor and a privilege to be here. So we started this procedure in 2020, and Mike, Dr. Reldon, actually was the first one picked it up and really advocated for this procedure, mainly for the patient's benefit. And today I will focus on this procedure and the outcomes and what we're thinking about how to manage those patients with aortic stenosis. So this is my disclosure. So for aortic valve disease, this is a couple pathology. One is aortic valve insufficiency. Those patients most time will repair them, and their annulus dilated, we make it smaller. And with the root aneurysm, we do valve spin roots and save the valve. The normal annular size for aortic annular size, we're talking about the echo annular size, about 19 to 25 millimeter. And when we do valve spin roots or root repair, we make it smaller from 30 to 25, 23. When you have a patient with this kind of valve, it's severely calcified, or have to replace it, and it really depends on the device and the prosthetic valve, how to do this. You cannot save those valves, but have to replace it. The valve repairing actually started in 1952. It's very interesting. First, the valve was placed in the descending thoracic aorta because we don't have cardiopulmonary bypass. Surgeons clamp descending aorta, put the valve in. That's first aortic valve, and Half-Lego did the first one. Then in 1957, Lady Hyde did another second one into cardiac, put in the LVOT, and of course it caused heart block. And that was how the pacemaker was born, and the Medtronic company started from there. In 1960, and the first, since we have cardiopulmonary bypass, then we developed one first case is cage ball aortic valve replacement. After that, AVR become a routine procedures to all the cardiac surgeons. So it's really a very common procedure, and everybody does it. And then after that time, it's all the development of prosthesis. If you look at the history of prosthesis development, this is all the mechanical valve. And I want to pay attention to all the valves has a sewing ring, has a rim and a strut and a housing. And this is the bioprosthetic valve. As you can tell, all the valves, same thing, they have sewing ring housing, and based on the design of the valve, we can see the opening of the valve can be bigger or smaller, even the same size. And the size labeling is very, very deceiving and doesn't tell you really the opening of the valve. So this is the first paper in 1978 by Dr. Rahitullah. At that time, he defined the patient, the prosthesis patient mismatch. The mismatch defined that originally said, even if the prosthetic valve opening is smaller than the original aortic valve opening, it's a mismatch. And he concluded at that time, all prosthesis, no matter mechanical valve or tissue valve, has mismatch immediately when we put it into the patient. If we don't upsize the valve, put it that way. If a patient have annulus 23, we put a 23 valve in the valve, the area immediately smaller than the patient's native annulus because of the housing on struts. So immediately we give patients the mismatch. So how big is our aortic annulus? It's not big. The average size for male is 23 millimeters. For females, 21 millimeter. That is why the most common valve used is size 21 or 23. You look at all the trials, you can ask Mike here, TAVR trial or large series reported in the literature, the most common used valve size is 23 or 21. Because we really don't do much enlargement of the root or the annulus. So what does that mean? When you have a 23 valve, this is a size 25 valve, and I found out this just by incidence, coincidence. The label is in internal diameters 24. That's never the opening of this valve. It's interstand, the metal frame is 24. So I tried the 24 size, push it through, it cannot pass at all. So I tried 22, I couldn't even pass 22. Eventually, before I put this valve into the patient, I can pass a 21 size, 21 millimeter. So before we do anything, put the valve inside the patient, it's about 4 millimeters smaller than the labeling. So once we put it into the patient, depends on how we do it, you use plages or have tissue protruding to the blood path. The opening even smaller. So I sized everyone now. Since I know this is a difference, I found out at size 25 valve, I don't use plages for AVRs. It's a subannular implantation. The opening of the valve, the 25 is 20, a 27 is about 21 to 22, a 29 valves, only 23 millimeter. Just remember the average man in the United States with annulus 23. I mean, all the gentlemen here has the annulus probably 23. You need the size 29 valve to match your native annulus. Otherwise, you get a mismatch, prosthesis patient mismatch. And in women here probably have annulus diameters about 21. It's echo diameter. You need the 27. If smaller women have a 19 millimeter annulus, you need the size 25. So we put a 21, 23 in our patients most of the time. What end up here? A 23 valve, the opening is about 16 millimeter. A 21 size 21 valve is 14 millimeter. So it's very small valve we put it in. So this is the slide from Bill and Northrop, and he said, this is really a nice illustration to show the difference of the sizing and the annular size and the opening of the EOA. And if the range is the patient's annular size and the nut is the valve, and this is the opening of the valve. And Biaco found out the average size of the valve is about 35 to 70% of original aortic annular area. It's so small. So we did a CT scan with same patient with the annular size of 23 basal ring with echo annulus. If we put 23 valve without upsize, the diameter is 17 millimeter. If you enlarge it, put the 27 top head mechanical valve, is about 23 millimeter. A Magellan E is 29, it's 23 millimeter. So we need to upsize by 3 valve sizes to have the valve opening to match patient's native annular size. That's the idea. We need to upsize the valves. So not just us. So because of the measurement, mislabeling of the valve sizes, FDA asked 4 major valve companies in the United States, including the well-known Medtronic, Edwards, Abbott, all 4. And they asked them to bring their standard valve to give to each lab of each company to test the opening of the valve. And they found out this method with 25 liters per minute, which is way above our normal cardiac output, tells us really the maximum opening of the valve. And the 4 labs from 4 different companies found a very consistent measurement. Look at 29 Magellan valve. It's very close to 23 millimeter. It's very close to our direct measurement. And the 27 Avalus is 21 millimeter. So the opening of the valve is about 5-7 millimeters smaller than the labeling. It's very small. So now FDA required each valve company to put this EOD, which is effective orifice diameter, on the box of the valve. And it's pretty much the same as you just see, 29, 24, 27, 21, 25, 19. It's about 6 millimeters smaller than the label. So what does that mean? So if patient has a annular size 23, the area is about 4.15 square centimeter, and we put the 23 valve in, it's 16 millimeter. So if you compare 2 area, you can see how much we reduce the area of the annular size of the aortic annulus to the patient, less than half. Basically, patient come in, if as a 23 annulus come in, we put a 23 valve in, we downsize the area by 52% immediately. So we convert severe stenosis probably to moderate stenosis. So I calculated all the valve based on from 19 to 25 millimeter annular size, about 3 to 5 square centimeter. And if you put the prosthetic valve in without the enlargement, the area is about 1 to 2.4. So we reduce the area if we don't enlarge the annular size, put a large valve in, by 50 to 60%. It's a lot of reduction if we don't do the annular enlargement for any patient with a normal annular size, 19 to 25 millimeter. So what's the downside of that besides the hemodynamics? This is same Dr. Ruhitula. And if we have the normal aortic annulus is 3 to 5 centimeters square, takes patient 40, 50, 60 years to develop critical stenosis. And if you have valve started from less than 2 here, it doesn't take much time to have increased gradient, have structural valve deterioration. Because the opening is so small, won't take much time. Everybody knows about the VIVA trial, compare the SAVA and the TAVR, right? TAVR is no better than SAVA valve area. Look at the small valve for patients who have annular less than 21.5. The valve size for surgical valves, 21. The area between TAVR and SAVA is about the same. 2 years, 1.4, 1.5 square centimeter. You started from 1.4, 1.5 here. Really takes no time. This have a high gradient. So have structural valve deterioration. Surgeons always say, we put a small valve in, the gradient is low. It's 10, 12, or 8. We have to think that moment in the OR, patients under general anesthesia, that's probably lowest cardiac requirement. So when the cardiac output is low, stroke volume is low, there's no difference. See, 200 here, there's not much difference between the 1.5 square centimeter to 2.5 square centimeter here. But when patient exercise, increase the cardiac output, look at between the valve, which has 1.5 square centimeter and 2.5 square centimeter, difference about 50 millimeter mercury. Every echo is done pretty much when patients lying there doing nothing at the rest. If you already see a gradient about in the teens, 20s, that valve won't last long, and the patient cannot exercise. And the quality of life will be much poor. So besides the structural deterioration, the quality of life and the exercise and the survival now. So this is a study we did at the University of Michigan, about more than 2,000 patients. We found out patients with the size 29 valve have the best long-term survival, 10 years. It's 23, 27. Among them, it's not much, it's no significant difference. And they're much worse than 29. 19 to 21 is way worse than the other two groups. Small valve do worse, and large valve do better. And you always hear the Ross procedure has a very good outcome, long-term survival. And the Ross procedure borrows the pulmonic valve, which has exactly the same size of aortic valve. So the hemodynamics is much better. They also say Ross procedure can bring the patient survival to general population. So we did the same analysis. We compared the different groups. This is a group with the size 29 valve. We compared to sex and age matched general population. The survival is identical. And look at this, the more detail here. The mean age, the median age is 61 years old. 99% are male, because male have big annulus, you get large valve without much enlargement. So then you look at the 23 to 27, size 23 to 27, mean age 66. 2/3 are male and 1/3 are female, right? The first 5 years, you match the general population. After that, drop dramatically compared to general population. This we don't do enlargement, just put the 23, 25 valve in. And the other group, 19 to 21, most of them are female, 94% female, age 75. We always say a 75-year-old lady put the 19 valve, 20 valve would be okay. No, it's not okay. Look at the survival. Much worse is general population. So that's, I hope, and the one last thing I want to say is the valve in valve down the road. We know, look at this study, it's about 2018 JACC. With the valve size 19 to 23, after the valve in valve, the gradient at discharge is close to 20 millimeter mercury when patients doing nothing. So you see how bad it is when I put a small valve in and the patient cannot have valve in valve down the road. So I hope for the first part, I just want to emphasize why we need to do the annular and root enlargement to give patients a large valve. Because with patient with a normal annular size 19 to 25 millimeter, without the enlargement, we just put the valve in based on the size, don't do any upsizing, you have immediately PPM, immediately. And we don't do much good to the patient. Then patient have high gradient, cannot exercise, poor quality of life. Fast structural valve deterioration, Notion trial told us this. And not good candidate down the road for TAVR, valve in valve TAVR, because the valve is small, root is small, STJ is small, and the decreased survival compared to general population. So I just want to convey the message for normal aortic annulus. You do not, if we don't upsize the valve, we really have not done much good to our patients. So how can we implant a large valve, upsize 3 valve sizes to a patient with normal annulus, which can only hold 21, 25 millimeter? And we developed this technique. Actually, it's a relatively simple, reproducible technique. And the Y-incision is split the commercial between the left and the lung, and into the left fibrous trigon and right fibrous trigon partially. You start at the nadir, you can free half of the left coronary sinus and the lung coronary sinus. Look at the specimen here, split between the left and long commissure into the left fibrous trigon, but not cut into the muscle, and then into the right fibrous trigon, not in the membrane septum. The conducting system is below in the muscular septum, so it's rarely you get the heart block. And the patch it with rectangular patch and with arc modification, and put the valve sutures as normally do. You have to imagine that this new left non-commercial should be here, this area, same height as those other two commercial for the valve stitches. So one criticism is says, this technique does not enlarge the LVOT. That is very correct. It does not enlarge the LVOT, does not enlarge the basal ring. Why we do not need to? When a patient comes to us with 50, 60 years old with aortic valve stenosis, the aortic valve stenotic, the basal ring, LVOT, it's normal. He was able to run marathon when he was young, play football, basketball when he was 20 years old. Valve becomes stenotic, LVOT is always normal. If we put a 23 valve in, as we mentioned, reduce area by 52, if we enlarge the surgical annulus, which is this crown-shaped surgical annulus, not the echo annulus, which is blue. The surgical annulus is where we put the sutures. The reason we enlarge the surgical annulus and the root is because we want to put a valve in this area. We do not put a valve into the basal ring or LVOT, right? So we enlarge the root and the surgical annulus, put a 29 in with the opening of 23. So there is no bottleneck. Blood flows easily from LVOT through the valve. It's all normal for this patient. We restore the opening of the valve as patient native annular size. So this is a quick video here. I do complete the aortotomy for first time, even second time, and for pretty much every patient, because the alignment is much better. The size for this patient is probably 23, like a normal man, and try lifting the aortic valve. And you cut really underneath the aortic annulus into the left fibrous trigon. And this side into the right fibrous trigon, which is right underneath the nadir of the non-coronary sinus here. Mammary septum is right there. Then this patch is about 5 centimeter wide. I cut about 4 centimeter. Make it wider. If it's too long, you can shorten it and cut it into narrower. Make a arc modification. The arc modification preserves the aortic mitral curtain and the flexibility of the aortic root, and also avoid the surgeons suture the mitral valve to the patch. So you sew along the triangle, the two sides of the triangular shape of the aortic mitral curtain. And this suture line has to be watertight. And I pay a lot of attention to this suture line here. And just sew it for probably running. Place the patch over the aortic mitral curtain, overlaps it for better hemostasis. If you see any dark here, just put another stitch there. So you transition to the aortic annulus from the nadir all the way up to the aortotomy. And secured with additional stitches so the suture line doesn't get loose. Same on the left side, first stitch further anchor the patch to the left fibrous trigon, then sew it to the aortic annulus from the nadir all the way up to the aortotomy here. Cover the aortic annulus with the patch, overlap it, sometimes debridement cause some damage of the aortic annulus. This all can help just secure this area. So you can see the root enlarged so much. And now you put a 29 in for this 23. And the valve sutures just normally do. You can do running, you can do horizontal mitras. If you used to use plagiates, you can use plagiates. But no, I never used the plagiates, and I just don't use plagiates. At the non-coronary sinus here, and at the nadir is the transitional stitch, straddle the corner here, further secure the corner. So I have not had a bleeding from the corner of the patch out of 190 cases. So this stitch actually very important. The most surgeons go from patch over there. That won't enlarge the root or upside the valve adequately. You have to come along the aortic annulus, has a vertical stitch coming up. Then the patch, because no plagiates, you just go inside, outside, and back inside here. So on the left side, the same stitch. And at the bottom is another transitional stitch securing this corner here. One through the native tissue, one through the patch. and under the aortic annulus. So another vertical stitch coming up here along the aortic annulus. It is AVR, aortic valve replacement. You have to go along the aortic annulus coming up, and then transition to the patch, finish the suture lines. So this is a 29 valve, and you make one strut facing the left or right, commercial, then two coronary on each side equally, so you want to block the coronaries. And I tied the stitches at the nadir of non-coronary sinus and left coronary sinus first. And the right coronary sinus is never a problem because the patch, sitting the valve sitting on the patch doesn't obstruct the right coronary. It's way high. So you can see the base ring preserved. This is a different case because this aorta smaller. I did a roof technique to enlarge the ascending aorta, set up for future valve in valve TAVR. Just make a vertical cut at the posterior side of ascending aorta and trim the patch in triangular shape, and then insert the triangular patch into the aortotomy, the longitudinal aortotomy, and close the aortotomy. I know Mike does it different closure, works well too. So you can different way close the aorta. Either way, it is good. And with the complete aortotomy and the roof technique, the ascending aorta, the root, it looks very natural. On the CT scan, you go for larger root, ascending enlarge, and taper it down to normal arch. So this operation is not a difficult operation. Once you do once, it's easy to do. This is 119 cases. We have done 190 now. The outcome is pretty much the same. We upsize from 21, most is 29. As mentioned, the 29 has the survival similar to the general population, upsize 3 to 4 valve sizes. And you can see the outcome is good. It's one mortality, which had the mitral, aortic, and CABG multiple procedures. Had the mesenteric ischemia, died from radiation, mesenteric vascular pathology. 2 heart block, one had the Gabodi fistula as endocarditis. For AS patient, the only one had the heart block because really we enlarged the root posteriorly far away from conducting system. So it's not a problem with the heart block. This is 2023 now. Majority, about 75, 78% is 29, size 29, and about 20% is 27, and then a few patients is 25. After this slide, in 2024, 2025, I had 3 patients get the valve size of 23. Those 2 are Turner syndrome, very short. Another one I just did before I came here. I can only put a 23 from 17 to 23. Her BS is 1.3, very small lady and from a Hispanic lady. So one question Michael and I discussed yesterday, talk about this. Say some surgeon told the cardiologist the valve is tilt. It's not good for valve in valve TAVR. The valve is not tilt. And as I mentioned, and if we do the technique correctly, this is a 23 valve, opposite 29. The valve sits very well, perpendicular flow. As you can see, how much space the struts, the housing taken of the valve. It's a 29 valve, opening is 23, LVOT, the basal ring is 23, it matches very well. Same applies to the mechanical valve. It's a 19 millimeter annulus. It's a very obese lady. And we enlarged to a 27 top head valve. The opening actually top head is bigger than the LVOT. So it's about 22 millimeter. So the valve, you can see, it's not tilt. It's perpendicular to the blood flow. And one thing we mentioned before, we do not enlarge the LVOT. And this we showed, this is 119 patients with follow-up echocardiogram. Look at the LVOT diameter before is 20 millimeter. And remember, the 70% of this population are female. After the surgeries, actually increased to 22 millimeter. It's not because we enlarged it. It's because of the regression of LVH and the LVOT open up more. And look at the mean gradient. Before surgery was 2. After surgery is 2. So LVOT in those patients, aortic valve stenosis patient is normal. And for adult patient, it's normal and the valve stenosis, you replace the valve. For pediatric population, they could have LVOT, hypoplastic LVOT. Those patients need a coronal to enlarge, but they are babies. We, adult cardiac surgeon, don't deal with those patients. Some patients with Holcomb or Webb, you resect the Webb, do a myectomy for those patients, then do an enlargement, put a large valve for aortic valve stenosis. And the root is enlarged from 27 to 40. And you really create the space around the valve to perfuse the coronary, even down the road for valve-in-valve TAVR. And I want to show here, this is a study done by our radiologist. They measured, this is about 50 cases, they measured the post-op CT scan, see if the anatomy, geometry after the enlargement is good for valve-in-valve TAVR or not. As you can see, the VTC, the valve to coronary distance, increased all the same, mild. The VTCs increased actually mildly, but no significant difference. It's about 4. The V2A STJ is massively enlarged. Actually, look at this, is from 4 to 8. It's from 4.5 to 5.7. There's a lot of space between the valve and STJ. It's very good for valve-in-valve TAVR. Also, it's very interesting here. But it's based on the CT scan, the pre-op CT scan 25, well, upper size 3 to 4 valve sizes is 26. It matches exactly the patient's native annulus by CT scan, this same modality, right? They're different from direct measurement. This reduce without any enlargement. The pre-op CT scan showed the annular size, the basal ring is 19. And after about 3-4 valve sizes, it's 26. Those two groups, the annular size, no difference during surgery. So you need upward 3-4 valve sizes to give patient the adequate size of valve. So this is an example. Patients have annulus 23. We enlarge the root, put a 29 in. You can see a lot of space between the valve and the coronaries. And the STJ from 27 to 38. It's wide open. There's no sequestration of the coronaries when we do valve-in-valve TAVR. There's plenty of space between the coronaries and the valve. The distance between the basal ring to the coronary shortened because it's supraannular implantation of the valve. No matter you enlarge the root or not, if we do supraannular AVR, the distance between the coronary and the valve will be shortened. There's another patient that we just did yesterday, showed nice anatomy of the valve sitting there. There's no tilt. There's a lot of space between the valve and the coronaries. This is probably ideal situation for this 29 valve for valve-in-valve TAVR down the road. Hemodynamic, and this is the flow. People asking, you put a large valve on top of this, does it change the flow or create like stasis? It does not. Actually, besides the hemodynamics much better, this is the one with the enlargement. This is virtual without enlargement. This is real patient matched without enlargement. You can see after without enlargement, this really have a lot of turbulence and the high flow. But with the enlargement, the flow is velocity much slower. And there's no stasis around the valve. There's no clot form around the valve with the enlargement and the large space and large valve. I call everybody and follow them every year, and I have not seen a thrombus around the valve. I do see 2 halt. One is enlarged, one is not enlarged with 29 valve, and we treated with the Aortic of 3 months. CT scan again, the halt goes away. Even in surgical valve, some patients could have halt, not just TAVR valve, but much less in surgical valve. So this is 3-year outcome now. And this is native valve, severe stenosis with the standard valve prosthesis, not mechanical valve, just standard valve prosthesis. You can see the EOAs keep going up because the regression of the LVOT and the better flow and the patients you really feel better. So EOAs calculated based on the LVOT area and the flow. So that's why the valve same size is larger than the patient actually, sometimes an annulus. So you can see the EOAs keep going up. And probably this is the best hemodynamics you can see in the literature. The gradient is going down from 6 to 5. It's normal gradient across our aortic valve, like us here is single digits. It's about 3 to 8. this EOA index keeps going up, and even jumped up like it's different from EOA, it's flat, it's like the same slope, but it's up. Why? Because the patient lose weight. Another patient is obese. The BSA dropped. We found a very interesting, BSA dropped. The EOAI actually increased faster than EOA because they can do more exercise with a large valve. And this is DI, this is a new parameter. You can see DI keeps going up. It's above 0.6. All the parameters showing a very, very nice hemodynamics at 3 years now. Time-wise. So one thing I want to mention is reoperation. Even with the reoperation, we can still do this enlargement very safely. This is a patient who had the NICS procedure. Annulus was 19, the upsize was 21. And the traditional way NICS and Manugian is not as effective. And the NICS can upsize by 1, Manugian no 1 to 2, but they worry about mitral regurgitation. When you do reduce, the same thing, you cut between left and the non. Make sure you cut down below the aortic annulus. That's where the plagiaris is. And most time you have to take all the plagiaris out. That's plagiaris there. And they cut down below the aortic annulus. And this is, you can see the right fibrous trigon here. See that? Yeah, to the later. And the patch the same way. This is early case. I didn't do the arc modification. Sometimes for the reduce, the aortic mitral curtain is completely destroyed. You just sew to the mitral annulus. It's okay, but not mitral anterior leaflets. Mitral annulus, the scar tissue is fine. So same thing from left fibrous trigon to right fibrous trigon, and from the later coming up. You can see the patch here from the NICS. You can maintain that and coming up. So this is a 19 millimeter annulus, basal ring, upsize to 21 by NICS. We took it out and put a size 27 valve in for this patient. The scar tissue, you be very careful. You want to take the old valve out. It's damage of the aortic annulus and sinus, and you need to sew to patch it to the annulus. Sometimes damage is covered with the patch. That can't repair it. This is 27 sizer and 27 valve go in. The same stitches, not the transitional stitch, just across the suture line. Have one strut facing the left and right. Make sure the corners on each side of the strut. So you can see after this is a 27 valve, this is 21, and it's much smaller. For redo actually it's a little more difficult than first time because the anatomy is not that clear and the root is damaged by the prosthetic valve. So you need to really cut down below the aortic annulus, but you can still do safely. Like the annulus we have is about 21, upsize about 3. Most common use the medium size 27, and it's still quite safe to do it. We have no mortality for about 50 patients now. The last I want to talk about is TAVR. As we know, TAVR, and most patients going to TAVR now. I want to show here, really, with the annular enlargement and the upsize 3 valve sizes, the hemodynamics is better than TAVR. As we know, TAVR, all the trials showed it's not inferior to SAVR because it makes sense, right? Put the same annulus, no enlargement. TAVR is the same hemodynamic. All survival so far has been the same size of the valve pretty much. And the TAVR is minimum invasive. That's why patients choose TAVR. If SAVR cannot do any better than TAVR, most patients will go to TAVR. So I'm showing here and how we can do better than TAVR because TAVR cannot do annular or root enlargement. Surgery can. Surgery can put a large valve and set the patient up for lifetime management. So TAVR valve is small too. I take every TAVR valve and measure it. It's 23 sapien, it's about 14, 15 millimeter opening. 26 sapien, 16 millimeter. I use the size, push as hard as I can to pass the TAVR valve, it's about 18 millimeter. So I have not explanted the 29 sapien yet. If I use that, I'll measure it. And you guys have so many TAVR explants and measure it yourself. You can see the real opening. 23 alveolus, 15 millimeter. It's very small. The labeling is very misleading. How about 34 alveolus? Does that mean opening 34 millimeter? No. You talk to the company, the opening is about 24.5 millimeter for 34 alveolus. That's pretty good because the largest opening, normal aortic valve, is 25 millimeter. So this is the case here, and it's a 74-year-old patient, and bicuspid valve, had a TAVR, 23, never felt better, and then had come to me with this severe AI and severe stenosis, moderate severe stenosis. You can see how small the root is. You can see the AI and the jets there, 23 sapien valve. So TAVR explant and Dr. Riordan and Marvin all have a lot of experience. It's not that difficult, if you do it right. You really need to do it sharply, cut it out, instead of just pulling it out. Once you take a TAVR valve out, actually, it's quite clean there for us to do the annular enlargement. Same thing, cut into the left and right fibrous trigon underneath the aortic annulus here. There's right fibrous trigon there. You can see the root enlarges so much. And the same technique with the patch and the arc modification here. And so from left the fibrous trigon to the right fibrous trigon. There's some tear of the aortic matrix, and I put the stitch to repair that. And this is size 25 valve here. And the same way I just described. Once you patch, enlarge it, it's about the same, and all the implantation and technique is the same. This technique actually is quite reproducible. In the surgeons all over the world and look at the video, they can just do it for their patients. So you can see how small the TAVR valve it is, the opening here, compared to the enlarged, 3 size up, 25 magnetic valve. So I think any patient would want this small TAVR valve and instead of the large, small TAVR valve instead of the large TAVR valve. If they are low intermediate risk, they can tolerate the operation. High-risk patient, TAVR works very well. So close is the same thing with the roof technique. Because this patient, the ascending aorta is very small. You enlarge the ascending aorta, the STG really helps set the patient up for the fusion valve involve TAVR. This is grading afterwards. So we compared to TAVR, we matched the annular size by CT scan and the ejection fraction. This is low risk to intermediate risk patients. Native aortic valve stenosis. You can see that the TAVR group, the EOA is pretty much stable. The SAVA group continues getting better, and the gradients continue getting smaller. And it's all significantly different from the very beginning at the 3-year follow-up. This is the EOAI, shows the same trend. With the enlargement, SAVA is better than TAVR. DI showed the same. For TAVR, it's very stable. It's about 0.055. For SAVA, it's keep getting better, above 0.6. LVH regression, you can see that this absolute regression is a percentage. For TAVR, it's about 15% the first year. This is consistent with the partner trial. They used partner trial patient that did a LVH regression. It's about 15% at the first year. Look at the SAVA with the enlargement, 40% LVH regression. This is in patient with moderate to severe LVH. It's very effective with the annular enlargement. PPM, no PPM, as you can imagine, no PPM in the enlargement group. TAVR group was about 19% moderate to severe PPM. In SAVA group, had 2 patients had the transvalvular leaking, mild, traced to mild AI, and you can see TAVR valve had the paravalvular transvalvular leaking about 26%, much higher. Survival, people say it's 2 different populations, doesn't make any, it's meaningless. But if you calculate the hazard ratio with the enlargement, it's about 0.15 hazard ratio. It's much better in the SAVA. And if we do a very, very extensive, all the parameter propensity score match, it's all less than 0.1, indicating a nice match. This is not p-value. This is SMD. Less than 0.1 is a very good match. The age is very close, 71, 72 group. And the comorbidity is all matched. Look at the survival. Because of sample size is small, it's not significantly different. But you can see survivals in the SAVA group 3 years. It's better than TAVR, but not significant. The last slide I want to show you is for the valve-involved TAVR. The valve-involved TAVR was based on the same size of previous SAVA valve. If you do valve-involved TAVR, you get better first year and the second year pretty much back to the original EOA. Look at we take all the valve out, upsize 3 valve sizes, the valve EOA is getting better and better. Gradient is going down to like really nice single digits, 6. It's like 16 here for the TAVR group. So for the SAVA, redo SAVA, when patients are candidate for SAVA, you really need to do an enlargement with a large valve. That's patient actually second chance. So in summary, at the University of Michigan now, we are thinking every AVR will consider annular enlargement to upsize 3 to 4 valve sizes. Unless this patient has dilated annulus, already 27, 29, we don't do it. Even 25, upsize to 29. It really provides much better hemodynamics, hopefully get better quality of life and the longevity of the valve. And it's really a good setup for valve-involved TAVR down the road. So I propose this and on Twitter and say that annular enlargement for AVR should be like LIMA in CABG. I got attacked by many, many people, but nobody's liking my statement. So for lifetime management, to us for no risk or intermediate risk, we think patient can live for another more than 10 years. Really, start first with the Y-incision upside 3 valve sizes. Hopefully this valve will last for 15, 20 years. If not, down the road, the valve-involved TAVR is already a low risk. If you need another open or another valve-involved TAVR, is still not high-risk operation. Thank you for your attention. Yes.
Bo, thank you so much. Wonderful data you presented to us, great technique. Tell us, how do we get this message out to the cardiac community, cardiac surgery community, and also the cardiology community?
That's a great question, and Mike, Dr. Relna is actually a great advocate, and he's talking about this, spreading the word at all the cardiology meeting and the cardiac surgery meeting. Thank you, Mike, for doing that. And I think, number one, we surgeons need to understand this operation, and it works really well. It's a simple, reproducible operation, and we can do better job. And for surgeon, we should ourselves should help others, cardiologists, and also train our residents to understand this procedure. Number two, we really need to tell our cardiology colleagues there's something we can offer to our low-risk patients with just probably better than TAVR and better for the lifetime management. We also need the long-term follow-up for our own data, and we're following those patients really every year now. We plan to do 5-year, 10-year follow-up data to show the long-term outcome.
What's the current rate of annular enlargement in the STS database? It's slowly gone up.
It's come up a little bit, as it used to be like 1 to 2%, now probably up to 3 to 4%. And in the state of Michigan, actually we do the multiple wet labs. Our centers are performing this, and pretty much most of the centers in Michigan doing that, and the rate of annular enlargement in the state of Michigan went up from 5 to 7% to 17 to 20%.
Bo, thank you very much. Great talk, as always. 2 questions. One is, you at your center and some select centers are very adept at doing annular enlargement, but other surgeons are not. So how do you scale this on a bigger scale in terms of training the surgeons and the residents and fellows? That's one question. And the second is, I'm sure you and, Dr. Atkins, Dr. Reardon do a CT on everyone, but not every AVR patient undergoes a CT because not every AS patient goes through the valve clinic. So how do you do this at University of Michigan? Are all AS patients going through the valve clinic? Is everybody getting a CT? So you know up front that they have a small annulus and they need to have an annular enlargement. How do you do this logistically?
Yeah, that's a great question. The first question, they teach the residents. This procedure, and it's not a difficult operation. The beauty of this operation is it's simpler, it's simple, and effective. And right now, all the cases, the enlargement is done by my fellows and the chief residents. They can all do this and teach them, go through this. And we have, as Marvin mentioned, the STS has been doing this for many years, for 3 years now, and a lot of other countries also doing this, do the wet lab. I think with the wet lab and with teaching, especially the younger generation, they exposed to this idea, they're very open to the idea of doing this and teach them how to do it. I think we'll have more and more surgeons doing it. Regarding the CT scan, yes, I think the CT scan is important before surgery and after surgery for the clinical practice, also for the research and compared to TAVR, compared to other modality. And we do CT scans pretty much for every patient before surgery, and after surgery for sure we do one because we want to make sure there's no pseudoaneurysm, no suture line problem, those things. And how to realistically have this to do it, I think surgeons now in the TAVR era have to have a mind now. Patients need a pre-op CT scan to help us plan surgery. And if for whatever reason they're missing, they didn't get a chance to do it, I think the key is you can always measure the basal ring, the annular size, the echoannular size directly in the OR and choose a valve with that opening EOA match that annulus, which is about 3 sizes up.
Gerald Laurie, thank you for coming down and your beautiful talk. I think you've clearly proven that you've got a very reliable technique that can produce a major enlargement of the root and produce much smaller gradients. But the discussion then switches to something which I think is much more controversial, which is just exactly what is the degree of aortic stenosis that is clinically significant in terms of relief of symptoms and patient survival. And I think we're still in the middle of the issue of determining that, because currently we've got a big discussion going on about asymptomatic people with severe aortic stenosis, and I don't think there's been a lot of discussion about operating on people with mild to moderate aortic stenosis, maybe a 20 millimeter gradient. So the issue is that you've introduced a technique which is obviously extremely valuable in people with small roots, but the other question you raised is to whom it should be applied, and I think the hypothesis that universal application of this will be a good thing is still not yet proven, and I'd be interested in Dr. Zogby's comments, because obviously we follow the ACC/AHA guidelines in choosing who will benefit from aortic valve replacement for aortic stenosis, and use criteria that are way beyond in other words, a more conventional approach using sort of standard criteria produces a gradient, and a low gradient, 15, 20 millimeters, and a valve area around 2. And the question is, are all these people really being ill-served? And I congratulate you on your efforts to try to show something, but your data is using Asian sex-matched population, which we've used a lot in the past ourselves because of the absence of anything better, is really a very crude assessment. And I think we really need to give some thought to the issue of just exactly what is the minimum that's a good result. The late Dr. Cooley, who obviously was in the era where you mentioned Dr. Ryan Tuller, and the prostheses were really bad. And in fact, we often were putting prostheses into people who actually made them worse. They had such poor hemodynamics. He had one of his favorite sayings was that no one's ever died from a valve that was too small. This was an era when after EOA came out, people were trying too hard to put valves in that were too big, and there were lots of deaths out in the community from people getting in trouble with coronary obstruction and other complications of excessively large valve replacements. So I'd really be interested in Dr. Zogby's comments on what he feels is the minimum gradient necessary to achieve to get a good, what we call a good result. And I'm not in any way advocating not doing root enlargement, and I think your technique's an outstanding technique. I think it's a real step forward. Thank you.
Thank you very much. That was lovely. Number one, I'm glad that you spent quite a bit of your time in your lecture to highlight that indeed there is a major difference between the size of published and the actually effective or anatomic area of these valves. I think that's been known for a while, but I'm so glad that the surgeons are thinking about it nowadays. And actually, this is not a deception from our colleagues in industry, but basically because all these valves were inserted by the surgeons, you need to know how much can you insert in a certain annular area. So with your technique, you are advocating a supraannular, basically, position of that valve. So the question now is, if we go supraannular, irrespective of enlarging it or not, how much do we gain? And I think maybe imaging would be, I think, very important in addition to the surgical, approach. And then the question is, how often do we need to enlarge it beyond a certain, certain size? I think we would gain quite a bit. We may gain 2 sizes, at least one, but we may gain 2 sizes or at times 3 sizes, depending on the true aortic root size. So, a question in your experience of how often that would happen. Because we have to weigh, you have the amazing expertise. I know our surgeons have amazing expertise, but if you're going to go worldwide, we want to make sure that we maintain safety and outcome of these patients, not only going after gradients. To answer Dr. Lowry's question, I'm really not sure. Obviously, the lower the better, but there is a threshold phenomenon. So I would think 23, minimum 23 valve, 25 valve, I think would give you enough hemodynamics, because we have to show that indeed even going lower than this is going to give an advantage to patients. So the first question I asked, the second question I ask you is, it's interesting to see the changes over time in some of the hemodynamics and effective orifice area. Do you have CT data to tell us that indeed the LVOT is enlarging over time? Because part of the LVOT is the thickness of the septum, and the septum can be very deformed in aortic stenosis. I would presume that some of that thickness is regressing in addition to the total LVH, and therefore it would add to this changing curve over time.
Yeah, you're absolutely right. We didn't do the CT scan consecutively, but we did echocardiogram. We did see the LVH of the septum and of the left ventricle regression actually very significantly. And then we measured the LVOT by echo, increased about 10% just the first year. And that's why the LVOT become bigger, the EOA calculate is bigger. I think it's continue, evolve this LVH, yeah.
Because that EOA is the one determining it, the other one is too big.
Yeah.
The EOA of the LVOT is the determinant.
Yeah. At the end is always the patient, the basal ring, the echo annulus at the basal ring, and determined. But after we enlarge it, if we do not enlarge it, it's the valve opening, because the valve opening is so much smaller than the basal ring, the native annulus. Yeah.
So a quick comment, then I'm going to ask you a question. First comment is, Bill, I know you're familiar with the national echo databases in Australia, where they've looked at gradients going up 0.5 meter per second and showed that any level of aortic stenosis cost you mortality, even mild. So if you're going to make your decision on the guidelines, once you make your decision, any level you leave hurts that patient long term. We have tons of data on that. So you might as well do as good as you can do. Now, in the low-risk trials, the amount of annular enlargements was less than 4%.
Yeah.
Because they were done from 2015 to 2019. We only had the Nixon-Nugian. We didn't have the Y-incision. I've told Medtronic we could rerun that. I could beat them, but they won't let me rerun it. What I'm hoping we can do, Bo, is that in the U.S., there's a movement to doing people below 65. We have no data on that. And I'm hoping we can run a 60 to 65-year-old randomized trial, surgery to TAVR, and then do appropriate annular enlargements. And I think that will give us some really good data. But my question is, how did you come up with this? What was the inspiration for doing your first Y annuloplasty?
Yeah, so before I answer that question, I do agree with both of your comments. I think we want to do the enlargement. We want to do it safely. And the safety in the community is not confirmed yet. So I think when surgeons, especially our fellows residents, you learn how to do this, you learn to do it well, do it safely, and so that's very important. And regarding how I come up with this idea, it's a coincidence. So I was doing a redo AVR for a 75-year-old lady who had a mechanical valve 30 years ago. She had a bicuspid aortic valve. That time the replaced was 25 St. Jude valve. And the aorta came to me when she was 75, and she had the aneurysm 6 centimeters. I was taking the aneurysm out, and she asked me if I can replace the mechanical valve with a tissue valve. She didn't want to take Coumadin anymore, so that's reasonable. So I took the mechanical valve out, and because the valve sewing is intra-annular, and so damaged the aorta mitral curtain below the left non-commissural, which we see often. So it's not a big deal. You patch it and close it, and you just put a valve in. So I debride everything. I size it. I can only put a 23 valve for this lady. I was thinking, she had a size 25 valve. I cannot give her a discount, put a 23 in. So I can do an enlargement. So I did a standard like Hemodynamic. I cut it down there, and because the 1/3 of the aorta mitral curtain underneath the left non-commissural was already gone. So cut that left non-open, so it opened up more, but I cannot close it anymore, and I have to patch it up. I patched it up. I was so easily able to put a 25 valve in. At the trigger, the said, well, I can go both ways. Then I said, how far I can go. Yesterday we were talking about in my early career, and I only did type A dissections and endocarditis because I don't have good referrals, and you take calls doing all those cases. Endocarditis patient, you frequently see the aorta mitral curtain is damaged. They have big hole there, but the trigon, the skeleton, never been damaged. So I think, I can cut as far as the trigon, to the trigon. So first case, was a small lady with aneurysm with probably 18, 19 millimeter, and had pancreas, a kidney transplant, very small lady, severe stenosis. So I cut it down with the Y. I was thinking before I had all the ideas before I did it. I cut it that far. I patched about 2.5 centimeter patch, the smallest patch I ever had, put in. I was able to upsize the 23 very easily. I was just so happy, I can put the 23 without cutting the mitral valve. So that was the first case. After that, I just put a bigger and bigger patch and upsize 3 full valve sizes. Yeah, I think we always try to do the best for the patient and they try to push the envelope. That will trigger sometimes new ideas.
Thank you for the amazing presentation. I have 2 questions. The first one is that, as we know, with the aortic annular enlargement, we are preventing the prosthesis mismatch, but on the flip side, we are increasing the LVOT, and there's a probability that the stroke volume can increase. So maybe physiologically, ascending aorta is not accustomed to the high stroke volume and high pressure. So is there any long-term data on ascending aortic aneurysm, dilatation, or dissection? And my second question is that in AVR, we are doing aortic annulus enlargement 2.5% of the times in the past before the Y-incision procedure. But the in-hospital mortality was more than the normal AVR, but the long-term mortality was better. So But my question is that in the prior procedures, like Cono and the NICS, the valve upsize was up to 3. But in Y procedure, the valve upsize is 4. So we are increasing the annular size more than what we used to do in the past. So although in the high operator volumes and high volume centers, there's not going to be a lot of mortality difference. But in patients, for example, when it becomes more common, for example, if someone is doing it in 2.5% of the patients, so there might be a longer mortality. There's going to be a lot of mortality in hospitals. So what are your thoughts on that?
So yeah, regarding your first question, so when we do the root or annular enlargement, ascending enlargement, most patients have small root, small ascending, so they don't have aortopathy. So I have not seen any patient have aneurysm or dissection per se. If a patient has aneurysm, has like above 4.5, I replace ascending as we normally do. If between 3.5 to 4, anything ascending above 3.5, we do not do that roof technique, enlarge the ascending anymore. We just sew a mismatch distal to proximal, just sew it back together. And it looks very good. You still have a ascending about 35 millimeter. So that's the number one question. And we do follow those patients with long-term CT scans, make sure don't develop root aneurysm. And this number one. Number two, the operative risk and mortality. I think you're right. And for surgeons, either another procedure doing root enlargement does add risk in general to the operation, to the operative mortality. I think we just need, like this morning, we're talking about LIMA to OAD, and Dr. Relda mentioned at the beginning, people don't want to use LIMA. They think it will increase mortality, those kind of things. They're just not used to it. Once we get used to use LIMA, now every case we use LIMA for CABG, right? And once they get used to this operation and well-trained and well-exposed, I think it'll be safer, but that takes some time.
Dr. Yang, Mehmet Hakan Akay, I'm one of the transplant surgeons, and it's a wonderful talk. Thank you very much. It's very inspiring too. I trained at Texas Heart Institute, and they used to say that time that, people used to come all over the world and watch all those wonderful surgeons, what they're doing. And going back, and they used to say that the Texas Heart Institute used to create a lot of mortality all around the world because people are trying to imitate what they are, our Texas heart surgeons are doing in the back home. So my early career as a cardiac surgeon, I was at UT. They used to send us to the Victoria, which is 100 miles south in the area in the hospital. We used to, with my partners, cover that area for every week. And I did like 78, 79 years old ladies with a nurse, and I put a lot of 90 millimeter aortic valve. No cardiologist complained, and most of them still living, I guess. So my question is this. I agree with what you're saying, but you can be driving your car with your feet and you're a wonderful driver in traffic, but it doesn't apply to everyone. So these kind of cases should refer to because you can, worldwide, this is a high expertise surgery, no matter what. LIMA, you can solve to the LIMA to the LAD, but this is a lot of people scared of this, seeing that. So these patients needs to be referred to the high volume experience centers. Is that will be the solution?
I don't know the question of that, the answer of that question, and I teach all my just I6 residents and my aortic fellow to do this operation, and I make sure they understand the principle in each step, and after finish, they go practice. Actually, they do well. They tell me those cases, but I do agree with you, and if a surgeon in practice never done this, any enlargement before, it is not that easy. Just you work on the pick hearts and start doing the patient may not. And I have surgeons come to our center probably here too to watch how we do it, and then they really get the nuance and those little details, then they know they think it's important. Maybe I didn't emphasize. So I do not have an answer to your question, but I think we do this operation first. We have to make sure we do it safely and get the patient live, and then we consider long-term. If the surgeon really feels and cannot do this, and it probably, I think it's good to refer to surgeon who does this more often and more comfortable with this approach.
But what do you think the learning curve is for this procedure? How many do you need to do to feel comfortable?
I think 5 would be enough. What do you think, Mike?
Yeah, sure. I mean, the difference between this and LIMA is that all the surgeons are doing lots of coronary bypass. They got to do LIMA. The average heart surgeon in the U.S. is doing 8 aortic valves a year.
That is
If
true.
you're doing 8 a year, it's hard to become, it's not like you're doing a couple coronaries every week. And so, yeah, I mean, listen, it'd be great if all aortic valve surgery came to centers, and we're probably not going to see a lot of this out in communities where they're doing 8 a year, because if they lose one patient, they don't have the denominator to kind of hide that. They're not going to get more cases. But in big centers, if you're going to make the decision to operate on somebody, it's hard to think, why not? And in our hands, we haven't found any increased mortality. I think, and ours are all being done by the residents. I believe that the residents are doing these very, very people. We have to do turnover installed. The reason it's so low at the trial is you could go up one size for most surgeons, and maybe 2.
Yeah.
But if you can go up, and that was a long run for a short slide. You go up 3 sizes, that makes a big difference. And so listen, thank you for coming. This is a tremendous talk. It's going to take a while for this to be adopted. And the reason it will eventually be adopted is when the cardiologists take this on and say, I want my patient coming back with this big a EOA, then the surgeons are going to follow suit. It was the cardiologists that really drove the LIMA. They realized the mortality. They quit sending cases to people who were doing vein. Once the cardiology community adopts it, they'll start sending the people who do it. But it's really great, and I enjoy the story about how you started this and what it shows. You should always be thinking about new things. You never know when the opportunity is going to come up, but you need to have the knowledge to see that opportunity. And this is now known worldwide. You should, great kudos for developing this and bringing it to the world. And thank you for coming. Really enjoyed the talk. Thank you.
Thank you, and it's a great time here.